Well, hello and welcome everyone. My name is Doug Nguyen, and I will be your moderator for this webinar panel. So thank you for joining us for this session with health effects of COVID-19 in minority communities today. We appreciate the time and energy you're dedicating to service on our virtual UCLA Volunteer Day presented by Westcom Foundation. During these unprecedented times, service organizations and leaders across campus have come together to create a day dedicated to volunteerism and promoting long-term sustainable service in a digital age. This year, the UCLA Volunteer Center is partnering with the USAC Community Service Commission and UCLA Student Affairs to coordinate today's events. The UCLA Volunteer Center works to connect students and community members to campus service organizations, opportunities through various events throughout the year. The Community Service Commission promotes ethical service on campus and in the community through affiliated student organizations, networking events, and advocacy campaigns. The UCLA Student Affairs is committed to maintaining the welfare of all students and giving back to the local community. So with that being said, we have a video of our chancellor.
Bruins, I'm delighted to welcome you to our 12th annual UCLA Volunteer Day. Of course, things are a little different this year. We aren't piling onto buses and fanning out across the city, but I'm so glad we're still coming together in the spirit of public service. The UCLA Volunteer Center, Community Service Commission, Student Affairs, and many other campus partners spent months reimagining this cherished event for our current times. I'm grateful to them, to the Westcom Foundation, and to our community partners for making this virtual day of service and learning happen. And I thank each of you for spending your Saturday with your fellow Bruins. Service is one of our true Bruin values, and it's core to UCLA as a public institution dedicated to the common good. We aim to instill a commitment to service early on through this event, which is a cornerstone experience for our incoming students. Over the years, Volunteer Day has grown to include any and all Bruins from around the world who want to join us in giving back to their communities. This kind of commitment is needed now more than ever, as so many people are struggling with the effects of the pandemic and meeting basic needs. I hope the experiences you have today will be enjoyable and will inspire you to continue volunteering and making a difference into the future. Thank you again and enjoy your session.
Well, thank you, Chancellor Block. And now we'll meet our panelists. So Dr. Khan.
Hi, everyone. Firstly, I want to say my heart goes out to everyone here. If you're struggling to build community at this time, lost someone in the pandemic or the endemic that is systemic racism, then I'm with you. And I want to recognize that it's great that you're all even here, and I recognize how tough it is. My name is Dr. Ayesha Khan. I'm an infectious diseases scientist and clinical microbiologist, a grassroots community organizer and educator, currently working at UT Health in Houston. I work on bridging science and medicine with social justice. As a researcher, I study antibiotic resistant superbugs, but as a clinician, I'm a clinical microbiologist, which means I specialize in the diagnosis of infectious diseases. And during COVID-19, I worked on developing and running COVID-19 testing, pandemic preparedness, as well as public policy. I'm a Bruin. I graduated from UCLA in 2015 as an international student, majoring in microbiology and global studies. I'm originally Indian. I was born in Bangalore, but immigrated at a young age, lived in several different countries growing up, and currently my activism focuses on a lot of racial justice issues, both here in America and back home as well. Thank you, and I'm really happy to be here.
Dr. Talamantes.
Good afternoon, everybody. Efrain Talamantes here. I'm Chief Operating Officer for Ultimate Health Services. We're the largest federally qualified health center. That's a designation by HRSA, the Human Health Resource Administration. And part of our role has been to, since the civil rights movement, to build community health centers with community. 51% of our board members are patients themselves. And so they really guide where we focus our efforts. We serve about 300,000 patients here in Southern California, Orange County. Los Angeles and Orange County. Most of them are Medi-Cal, or what we call maybe underinsured and also uninsured patients. About 20% of our patients have no insurance. We don't turn anybody away. We've seen the impact of COVID-19 pandemic. We saw it way before this pandemic, the social inequalities, the lack of structure, systemic racism, all that has just been exacerbated. So really happy to share some of my thoughts. I am a primary care physician. I still practice at UltiMed, have the opportunity to see patients, have diagnosed probably a lot more cancers in the last several weeks. There's also this idea that folks are foregoing care today. They're not going to healthcare because they're afraid. And so I really want to, champion all of us to make sure that we do our part in service and get our patients to care before they get sick. That's really where we're at, is prevention, but also detecting and getting people to the right care. So really happy to share, really excited to be in this virtual space. In 1997, when I was at UCLA, I was the first class to get an email. So it gives you a good sense of how long we've come. And I would have never imagined that we'd be talking this way or having this kind of venue. So really appreciate all the organizers and the leadership for putting this together. Thank you.
And Dr. May.
Good afternoon, everyone. My name is Folasade May. I am a health services researcher and gastroenterologist and internist. I work at UCLA Health, and I also work in the Veterans Affairs. I spend actually the majority of my time doing clinical research, and I have a research team that focuses in health equity. We do work that spans from looking at how we as health systems can do a better job of eliminating discrimination in our work and improving the quality of work that we provide for all types of patients, including patients that come from marginalized or underserved backgrounds. And in addition, our group focuses specifically on primary care prevention or health prevention. And many of our studies focus on cancer prevention. And it's very timely that that just came up, because we are seeing, in addition to the COVID pandemic, a problem with emerging crises in other parts of the healthcare system. And I look forward to talking about that a little bit today. But I want to commend the team for being able to host this event today, despite everything that's been going on. And I think that now is especially a time to be focusing on volunteerism, whether it's domestically or internationally. And I really look forward to talking to everyone and answering some questions and getting into how COVID-19 is impacting minority communities.
All right, thank you very much. So since we've now just met our panelists, let us move on to the questions. So our first question is directed to all three of our panelists. What does racial discrimination in the healthcare system look like? And how does this lead to unequal health treatment for marginalized people?
I can start us off. Sure, I'm sure we all have something to say about this because it's something that we all are experiencing, even before COVID, but especially now. And I think what we've seen in this year, this disaster that we call 2020, is the opportunity to at least highlight some of the disparities and problems with health equity that we have had in our nation. And these predate COVID, but I think have been amplified during the COVID pandemic. We know that, for example, Black women in this country are, 200% more likely to die during pregnancy or childbirth. We know, for example, that Black infants in this country are twice as likely to die within a year of being born than white infants in this country. So we've had a problem with inequities in healthcare and health outcomes for quite some time. We know that this problem is rooted in many factors, and I like to always bring us back to social determinants of health, which are the root causes of how we live in this country and in the world that have long-term impacts on your health outcomes. And we in public health often think of those as upstream factors and downstream factors. So the upstream factors being the things that are most central to how we live and work. And those are things like social policies, government, insurance policy, and and how we even live in our environment. So the example I always give my students is where you're born and the neighborhood that you're born in many times can even impact your health outcomes. So if you happen to be born in an area where there are food deserts, or you don't have access to playgrounds, you're more likely to have diets that are not enriched or nourishing. You're less likely to be physically active, and you're more likely to have the downstream health effects like obesity and diabetes and cancers. And a lot of our work focuses on that. Why do we have this problem? Again, I think that there are many factors that are contributing, and part of it, unfortunately, is discrimination. And sometimes these are conscious actions of discrimination that happen in our healthcare system. Many times there are unconscious or subconscious biases that enter how we care for patients in our health systems and in our clinics. In addition to those factors, we know as well that some of the ways that we just deliver healthcare, some of the research we do is inherently biased. So a lot of research studies, for example, might not include a diverse, rich sampling of the population. Or we might have algorithms that we base our medical care and medical treatments off of. We might not have included Latinos or African Americans or diverse group in those algorithms. And because of that, we have poorer outcomes in those groups. So those are some of the factors that we've been highlighting, and some of the factors that I think have been going on for quite some time in our country.
And I would also say that a lot of what I do is trying to look back at history and trying to explain to people why where we are makes a lot of sense when we think about the context of the country that we live in. And racism is something that's seen as, outside of science and medicine, when in fact it's ingrained in the foundations of the healthcare system. And that's if we remember that America is a settler colonial nation that's established on the genocide of indigenous people and expanded via the enslavement and exploitation of Black people. And that means that fundamentally all of the systems and institutions that exist in this country, including healthcare, which is a system, are not made for people of color and aren't established for people of color. They're in fact established by colonial oppressors. And I think keeping that history in mind is really important, because fundamentally to create healthcare in America, that required an erasure of indigenous healthcare systems and removing other types of healthcare that contextualized our community, that kept in mind how important it is to not just look at the individual when thinking about healthcare, right? And thinking about community health and public health and preventative health and mental health. And that these are parts of our culture as brown, Black communities, that's what we come in with. And that's something that's been so separated from science and medicine in America. And this history is not something that's taught in graduate school or medical school at all. And not having that context when you have that Black or brown patient that walks into your room, and if you have no idea of all of the systemic racism that they're experiencing and how that influences their community and their individual health outcomes, I think that leads to the biggest problem we're having today, which is that with COVID-19, Black, Indigenous, Latino people are indeed dying at 4 to 6 times higher rates than white people, but people call that race being a risk factor for COVID-19. And that's how we talk about a lot of illnesses, actually, when we say race is a risk factor. But it's not race, because race is a social construct that's not real, right? Arbitrarily deciding that there's something biological, like the color of our skin, to separate us. But it's racism that's a risk factor for COVID-19. And I think that getting people to think about that, and getting people to think about why, when we talk about racial disparities, we say, even with COVID-19, maybe we get to the point of saying certain communities have higher rates of chronic illnesses like diabetes and hypertension, but there's no mention of the root cause for why those particular communities are more susceptible to chronic illnesses. And once people understand that, COVID-19 infection and mortality rates are higher because not just are these communities more exposed to COVID-19, but they have a greater chronic burden of burden of infectious diseases due to chronic illnesses because of poverty and systemic discrimination and police violence and exposure to toxic pollutants in their air or water, mass incarceration, unemployment, and, like was just talked about, food deserts, lack of access to healthcare, public housing, education, transportation. That's the risk factor, not race. And unfortunately, we're still there in the field where we don't talk about any of that. And in our research journals, if you look at how we publish our research, we stopped at race.
Mhm.
And then that's the conclusion. And I think that's why we're here today.
Well, super inspired by this panel. I mean, it's a woke panel. I really appreciate a lot of the comments that have been shared. And yeah, I mean, we're still practicing what I call, unfortunately and fortunately, for whatever you want, however you want to take it, old white medicine. I mean, when we think about the Flexner report about 100 years ago now, he really set the stage for healthcare to be elitist and to basically not allow, demolished, dismantled Black medical schools at the time, because Black people were not allowed to go to medical school. And therefore, the history of healthcare and the professionals, the people, are really mainly white. And they've created these policies, intentionally or unintentionally, to create a system that only serves a certain segment of our population. They're starting to realize, I have many mentors who are white, and I really have helped me tremendously, but they're starting to realize that if they don't include us in this process, there is no healing. And so when I woke up, pandemic, and we found ourselves as a health center in testing deserts, there was no testing, meaning that the news was capturing, saying, man, East LA, there's no cases out there. What are they doing? Well, we're not testing because we didn't have access to tests. Fast forward, we started testing. We set up all our health centers. We're in very impoverished communities. We know this well because these are our patients. And the positivity rate was hitting 25% when the county we're in was 6%, 7%, 10% at tops during the surge. And these were grandparents, parents, uncles, aunts, moms, dads. And they were just telling us, okay, so now I'm positive and my employer won't let me go back to work. I don't qualify for support I don't have the proper documentation, this, that. And so you could see how this pandemic has ravaged and only exacerbated these disparities because the healthcare system to begin with has been faulty, right? The ACA has attempted to fix a 100-year-old problem, but we only got 7 years. And now folks are talking about dismantling it.
Mhm.
If we dismantled the ACA, I wouldn't exist in this healthcare system, in these health centers. And I can imagine the 60,000 people that we tested and said, the 20% of them that were positive, we were able to keep them safe and treated and got to the hospital when they needed it. We wouldn't be there. And so as I hear you all committed to service, also think about our role in being activists to make sure we exercise our right to vote. We vote for those that can't vote, the voiceless, but also really collaborate across. I think as physicians, we've started to realize we got to do more. And we have to partner with community. We have to be with community, not there to say, here, I have all the answers, as much as tell me what's broken and help me understand how we can fix it together. And that process, although it seems simple, is a commitment. It's a journey. It's something that you have to start somewhere. And when I was an undergrad, and the first experience I had, and the reason I got into healthcare was I had the opportunity to interpret for patients and tell physicians their story. And those stories always motivated me when I was trying to get through that chemistry and biology and all those physics classes that you have to take as a pre-health major or med major. So I would say that there's a lot of work. There's a lot of great people. I would say that your generations, the younger generations here present, you get this a lot more than we do. I think the older generations. hold us accountable. You know, when you have mentors, help us understand what's really happening. As you go higher in our training and education and our professions, we forget the reality. And so bring us back to that.
I think this is actually really inspiring conversation. And I want to add to this that it's also a numbers problem. I mean, you have the three of us who are sitting here and talking to you about this, but we are so few in medicine. I'm a Black woman in medicine. We are 2% of physicians. So we do have a problem in that the people who are interested in these issues and who are potentially more exposed to these topics as they're in their own community are less likely to go into health fields. We know there are studies that show that when Black patients are being cared for by Black doctors, they have better health outcomes. And yes, we need to break down what's happening when Black patients are in the care of non-Black doctors, and there are a lot of factors there, but it emphasizes the importance of having everyone in the room and everyone at the table. So part of this problem is that part of the problem with the discrimination is the lack of representation. And on top of this layering of the problems with the system and the problem even beyond the system, the problems with society are the problems with representation within healthcare.
So moving on to the next question. Thank you, Dr. May. So this question is for Dr. Khan, but this is a friendly reminder to the other panelists that they're free to chime in. So Dr. Khan, can you explain how flawed historical and modern research has led to the creation of the social concept of race, and what fallacies are used to justify the mismanagement of patients of color today? You have 5 minutes.
Okay, that's a loaded question for 5 minutes, but I'm going to try. So the way that race is addressed in medicine is largely seen of as it's a biological reality, right? And it's not. Neither is ethnicity. So science and healthcare, again, are built on those arbitrary constructs. And even though we may self-identify, ultimately our determination is determined by the government. And that's really how we as scientists collect data. It's based on what the government gives us as an identifier. So something as someone who's Middle Eastern is white in the system, and they do not identify as that, right? So it doesn't really matter. That's what I need people to, I guess, understand how big of a social construct it really is, because what we may identify ourselves is not really ultimately what's coming out to be. So in America, to make that construct stick, scientific studies have been used with flawed research, completely flawed research that have been debunked over and over again, to initially claim that it is in fact an intrinsic biological difference between races that creates the concept of race. So studies attempted to show fallacies like Black people having thicker skin, smaller skulls, larger sex organs, susceptibility to certain illnesses, immunity to certain illnesses, which all of this was ultimately a way to justify dehumanizing them and creating scientific support for white supremacy. And this isn't new. This has happened with creating the construct of gender. Using scientific research to arbitrarily create some flawed conclusion that certain people are weaker than others based on metrics that don't make sense with lacking the proper controls. So it's really just bad science, right? When we think about it, when we look back, it is bad science. But today these fallacies still exist and have been propagating. But when we think about COVID-19, for example, and think about why people still use race as a risk factor, it's because we're still not beyond that point, and research still is very much like this. And I don't think a lot of us recognize why. So even, for example, because Dr. May just brought this up, Black women do die more after childbirth. Black newborn babies are 3 times more likely to die as well. And we just stop there, right? But we don't look at the studies that do show that white doctors are more likely to think that Black people are more tolerant to pain, which is a racist fallacy, which causes them to ignore symptoms and leading to more neglect and misdiagnosis and mistreatment. And when we think about Black fetal and maternal health, there's been a more recent study that showed that, again, just as was cited, that Black newborns are 3 times more likely to die if cared for by white doctors and more likely to survive if they're cared for by Black doctors. So that shows us that this isn't just a historical problem. And we know of the history. So we know of the Tuskegee study that clearly shows to us a blatant example of where communities of color have been quite literally abused for the purpose of research, or something as simple as Henrietta Lacks, where someone without their consent is used until today. Her cells are being profited off of, right, in this capitalist system. But that's not historical. Our studies still look like this. If I look at biomedical research in my field, infectious diseases, and other fields, it's that, and that's what I mean by there's not enough of us, like Dr. May just said, that when we ourselves look at our own studies that are being done in the field, they're not being done the right way. And we have to exist within these systems, caring for patients, doing research, sometimes being the only ones trying to do everything. And I think if people understand how hard that is, and unless everyone begins to really understand how much of a fallacy all of this is, and these aren't real biological concepts, and that these are being used to justify dehumanization and oppression, we won't really make a lot of ground. And I feel like we go through these cycles where something crazy happens in this country and everyone's reactionary, right? Like everyone suddenly wants to talk about race, and it's always the same people talking about race. And we can't stop talking about race because this is our lived experience, reality, and we this is everything. This defines our experience. So unless allies really get up and are able to commit to this process, and I think, like you brought a really good point up, Dr. Talamantes, like in saying that it's not about just reading and learning, it's doing this every day, committing to this in your interpersonal relationships on the systemic level as you go to school, and thinking about it everywhere you go, because we have to think about it everywhere we go. And it's the least that can be done to show real allyship.
I'm sitting here shaking my head and nodding because it's hitting me to my core, because I recently had this experience where we submitted a paper, and the paper was showing that race and ethnicity were associated with the outcome that we were looking at. And in our discussion, we talked about why that might be. We talked about how systemic racism or structural racism in the healthcare system and discrimination, we said frank discrimination about how providers care for Black patients is a factor. And literally the response we got back from the editors was, can we say this a different way? How do you know it's discrimination? We just want to make sure that that's based in something. Is there a reference you can use? So we're still not ready for this hard-hitting reality. And very recently, some of our colleagues wrote a piece in Health Affairs where they actually documented how many medical journals and how many articles in the last years have actually used the word racism. And it's far too many papers. And even authors and researchers who are writing about race and writing about health disparities aren't using the word racism when they describe what's causing these differences. So there needs to be a shift. There needs to be a shift in how we think about these things, how we look at them, how we go back to the root causes and not just stop at race, as Dr. Khan just mentioned, and really diving into what we can do to change about this system so that we don't continue to have these problems moving forward. I'll briefly add that, I think when I did my PhD in health policy and health management at UCLA, and it's an extraordinary program. And for me, I was able to do it later in my career after I had finished my medical training, and I was able to go back and look at public health and try to understand how these social constructs are impacting how I cared for patients in the clinic and in the hospital. And I remember revisiting this concept of mistrust. And I remember in medical school, people saying, well, the reason why Blacks and Latinos don't have such good healthcare is because they don't trust the system and they don't come in for their appointments. But that's not what's going on here. You have to realize that there are historical reasons why there is mistrust. And that mistrust is rightful. We have had studies, we've had frank violation of Black and brown bodies. And because of that, there is a lot of hesitancy about what's going to be done with our bodies, what's going to be done with our cells, how are we going to be studied? And that, unfortunately, has led to some hesitancy in seeking care at times. And unfortunately, there are poor downstream outcomes from that. But the mistrust is not a reflection on Black and brown people. It's a reflection of the system.
And I'll say really quickly, a good example is seeing healthcare providers themselves navigate the healthcare system and being of color. I myself have gone and been misdiagnosed when I know what's going on with me because I work on that specific field because I'm not being listened to. And I'm not being believed when it comes to my own symptoms, right? So we navigate the healthcare system ourselves with mistrust. And that's where I advocate for my family and my community members and my patients in a completely different way, because I know exactly how this works because it's been done to me. And it doesn't mean that just because I understand and I'm a part of, science and medicine as it exists, that means that I'm immune to the way that we're treated, right? Because at the end of the day, people look at me, see how I look, and they respond accordingly. And that's always more important than them waiting to see what degrees I have, right? And it doesn't really matter. And I think that's something that's very visceral for us, that we can never escape that, it will follow you around. And the other thing that was interesting, I had it pulled up really quickly, so I'll say it. Biomedical research, it's been looked at. So even if they do use, like Dr. May said, if they do use the word race and ethnicity, it's been looked at to see how accurately do they use it. And again, this is looking at all biomedical research, major research journals, anytime before 2015. And they found out that only 20% of those papers actually define what they mean by race and ethnicity, like even basic definition. And out of those, 80% of the papers that made a big claim that race or ethnicity had something to do with their conclusions provide absolutely no explanation or no idea for, like, no further conclusions. They just say that and then they move on. So this is the research that we're relying on when we build medical practice. Entire medical devices are built on these understandings, right? We still have spirometers, which is like a way for us to measure lung capacity, that is still built on a race correction that comes from research that doesn't really have a lot of support besides flawed studies like this that say that Black people have 20% less lung capacity. Mm-hmm. So this is the type of research we're building and creating our healthcare system off of. And we're not just us doing the work is not going to be enough.
Okay, moving on to the next question. So for Dr. May, can you elaborate on other impacts of the pandemic? So for example, there seems to be a decreasing number of cancer screening rates during this time.
Absolutely. And, I think we could, there's still a lot to share about COVID-19 and how it's impacting our communities. But I think one of the other things that we're going to learn at the tail end of this pandemic are the other adverse health outcomes that we're going to have because of the pandemic. So in March, we had a shutdown. And we had the Surgeon General say, for example, that even non-urgent elective procedures and surgeries should be halted as we as a nation try to understand how to control and contain this virus. And that was appropriate. There was so little that we knew. We had seen what was happening in other nations around the world. We weren't quite ready to mask up and to social distance. People didn't even know what that meant. It was very confusing. So it made sense for everything to stop. And in healthcare, it was such a strange time. The clinics were empty, the hospitals were empty. We really hadn't even gotten our virtual telehealth platforms up yet. Along with that practice though, we stopped all of our routine care. So all the people who were due for their general routine primary care visits, all of the people who were due for their cancer screening, that did not happen in March and April. And since then, we've come up with safe policies to bring patients back into our hospitals and clinics. We've done things like start telemedicine so that you don't need to come in, but even for the people who have to come in, we've started social distancing in the hospital. We have providers that are wearing the appropriate PPE when available. We have masks that we can tell patients to wear, and those are widely available. So we can actually now safely start to administer healthcare again. But the problem is that the community hasn't gotten the message. And what we're seeing on the cancer side is patients are saying things like, I know I'm due for my breast cancer screening. I know I'm due for my colon cancer screening, but I'm going to wait until after COVID because I don't want to go to a health system right now. I don't want to go to a health center. I know that's where all the COVID patients are. The problem with this, though, is that models are showing that we're going to have a massive increase in the number of colon, cervical, and breast cancer diagnoses in the next 1 to 5 years because patients are delaying their life-saving cancer screening. The area that I work in particular is colon cancer screening. Colon cancer is the second most common cause of cancer-related deaths in the United States. It impacts men and women. And the thing about colon cancer is when we detect it early, we can save people's lives. We can resect the cancer and you can go on to live a full survivorhood. But if we detect it late, so stage 4 disease, your survival is only 11%. So the goal of colon prevention strategies as a nation has always been to find these cancers early. Now, when we have patients that are saying, I'm going to wait 7 months to come in and get my cancer screening, they're going to be presenting with very late stage cancers that we don't have the technology to do much about. And that's part of the devastation that's happening right now during this pandemic. Rightfully, we need to pay a lot of attention to COVID, but we need to get the messaging out there that there are safe ways to do these tests. In many cases, there are even tests that we can do for cancer screening at home or bring you safely into the health system so that we don't continue to have this problem. There was actually a study I'll mention briefly that just came out last week that showed, it was a modeling study, so it's imperfect, it's trying to tell the future, but they're using the best estimates. And they think that the number of breast and colon cancer rates, incidence, or the incidence of breast and colon cancer is going to increase by 10 to 20,000 just because of the delays in screening. And they think that the mortality, so the death from colon cancer is going to be larger than we've seen in years, because patients aren't coming in to have colonoscopies and other screening exams.
Yeah, just to build off Dr. May's comments, I mean, we know that racism does lead eventually to death. I mean, we've seen countless examples of it. And in healthcare, we're not immune to it. I mean, we can go and talk all we want about what's happening in law enforcement and how those biases lead to senseless killings of Black brothers and sisters. But in healthcare, we have the same challenges. When I was training as a resident in internal medicine, I remember clearly going to my attending physician, that's my supervisor, and saying, I have this Black woman, she's coming in, she's got this right lower back flank pain. I think she's got a kidney stone. Let's give her some morphine. Let's make sure she's, not in pain. She's like raving in pain, almost hopping off her bed. And he said, no. He said, that lady's always here and she's probably just drug seeking. She just wants a hit. I'm not going to authorize you to give her morphine. Mm-hmm. About an hour later, of course, she had a huge nugget. I mean, the size of a golf ball. And I felt horrible because I was trying to advocate for a patient, but the system in that case failed that patient. And that's really what we're talking about here, is that whether you identify as people of color, or whether you identify with one race or many races, I think there's a lot of intersectionality now too. You got to think about it's not just being Black, it's being Black and transgender. It's being Black and transgender and living in a zip code. It's very different. And I think as America, I think what we're really trying to show is we could do better. We have the talent, we have the people, we need to be included. We need to take, when we talk about equity, it's about making things better, but we got to call it out. Equity means that we have to identify every barrier, but not just identify it. I think we heard that from Dr. Khan. We got to tear down that barrier, because we can't just be putting band-aids and saying, well, we're going to do it this way for that and this way for this way, because there will be a community that falls through the cracks. And so, we've seen this with virtual care. We're super excited to do this. We're super excited to bring digital care, virtual care, all these technologies. People always tell us, well, just implement technology. It's not in Spanish. It's not in Chinese. It's not in all these other languages that we serve in our community health centers. And it takes us so much time and energy to adapt those technologies. And then inherently, the pictures that they use within the technologies, it doesn't reflect the community. Mm-hmm. It's mainly lighter skinned Latinos, or whiter, what we would call white Latino. And that's really unfortunate, because again, the system, those folks out there in technology, if you end up going into tech, please be inclusive. Listen to those individuals that maybe you feel aren't good enough to be in tech, right? Include them, because most of the time it ends up being those of us who are marginalized. I still remember I got my MBA in Atlanta at Emory University, and people would always come up to me and say, "Man, you speak some really good Spanish." I mean English. I'm sorry, but they were assuming I spoke only Spanish. Where did you learn English? It's like, man, I'm from Los Angeles. I'm from California. But it gives you a good sense that, you know, we're already perceived to not have enough or be good enough in the system. So those are the kinds of things that we're all really pushing to change. And it is policy, because these policies oftentimes are short because we don't have good evidence. We weren't inclusive in those research studies, and or the people making the policy are putting judgment into those policies about people they don't even know, they never interacted with. So those are just some comments. Thank you.
So next question for Dr. Talamantes. Do you mind providing some data in terms of positivity rates for COVID-19 in the communities that Ultimate typically serves? And are there specific zip codes that account for a higher percentage of positive COVID-19 cases?
Yeah, so the state just put out an equity index, and it's a real attempt at trying to understand zip code level, actually down to the census tract, which is even more granular than zip codes, because we all know we could live in a zip code, you cross the street, and it's a very different situation. And what really we found ourselves was within the community health centers that we serve, most of our patients were the grocery workers, were folks that are caretakers, folks working in the meat packing industry. We started to hear about early on that none of those places or none of those workplaces were providing them with any type of protection, whether it's screening, right, COVID-19 screening, testing, or even just having a mask or gloves or face shields. So we already started to see that these patients were going to start being impacted by COVID, and soon enough, as we started testing more and more, we started to see that the rates were about 20%, like I shared earlier, compared to the county where it was about 6%. And as you can imagine, I mean, you can almost, I don't even have to ask you to go and look up the zip code and determine what's happening in those communities. Many of us could tell you what exactly is happening in those communities. We can tell you what those communities look like. We can close our eyes and describe the people who live there because we know it, right? We know who's marginalized in this country, but we don't do much about it. We just let it be. So that's where we have to really come together. And again, there's civic engagement. Many of us may not think we're political, or I was a fool when I was an undergrad, and I used to say, you know what, I don't get into politics. But believe me when I say healthcare is political. And if you're going to go into healthcare, whether you take a side or not take a side, you're taking a stance. And not taking a side is taking a stance on accepting the status quo, accepting that this is the best we could do. But if you take the right side, and that's the equity side, we could do better. And really, that's the commitment that we've had to our patients is, one, not only doing all this testing, but holding our community partners and working with them around the table, getting them around the table to really have these discussions about what are we going to do, not just to provide medical services, but to really educate the community and translate, interpret all these messages that were coming from the CDC. And let me tell you how foolish of a guidance we were given, right? It's straight from the CDC. We just printed it out to say, please isolate at home. How embarrassing is that when I give a patient who doesn't have a home, who's homeless, this CDC guidance? I mean, that's systemic racism to its full effect, because most of our patients are, again, you already know exactly what these communities look like, and that's just not unacceptable. And so those are the kinds of issues we're seeing across. I think that this pandemic has really raised to the top. I hope really, again, that your commitment and all of us in this work do make significant headway. Look at the equity index, and I would say two things. One is that the reality around some of what we're talking about is that it's pretty complex. It's deceivingly simple. I know I do a lot of interviews for med school, and a lot of well-intentioned Black and brown applicants will tell me, well, the problem is that these communities don't know enough. They lack education. They don't understand. And again, it goes back to they don't trust us or they don't trust the system. And rarely, but more, I would say there's more of us starting to realize, hey, we're the problem too. I recognize that I'm part of a system that is broken, but this is what I'm trying to do. These are the steps I took as an undergrad or as a master's student or as a PhD student or as a medical student to try to change the narrative, to try to change how we approach and care for patients. And that's really what we want. I think for most of us, and I'm sure some folks too, when they hear this, they feel guilty. Don't feel guilty. It's more about doing something. It's more about say, how can I contribute? And the one contribution I think that has been the most important is that there's actually people listening to me, because before I would get discredited. Oh, you're the guy that just wants to talk about race all the time.
Mm-hmm.
Oh, you want to be the pity this community, this, that. And really it's not. I think it's really calling out where our system is falling short. It's holding myself and us accountable, and really that we could do better. And we have seen that as a community health center, as we started to really implement community informed healthcare, we see that we were able to test so many people because they trust us. We've overcome that barrier, right? They were coming to us willingly, and the system was asking us to collect information on everything, even when they don't have an address, including asking them for documentation. And they were willing to do that within our system because we were providing those safety guards, and we were assuring them that we would do everything we can. But again, that takes a very intentional effort in order to be successful. And then to go back and use that information to advocate. So we constantly go back to the state government, national government, and show them that we need to do more and we can do better. And that's really important as you move forward through your career.
And I'll say two really quick things because that brought up a really good point, that when we're talking about these issues, I think for everyone here, it's really important to allow yourself some kindness when you go through your education. You'll realize looking back, I mean, if I look back and see the things that I said or the things that I might, I've been complicit in upholding. I am complicit. I pay taxes to this country. So I am actively complicit and upholding systems of oppression. And the problem is to never let yourself feel that discomfort and run away from it. Feel being called out and walk away because you feel like you did something wrong and you don't want to engage with the information anymore. That discomfort that you feel when you're being called out, or if you recognize that you did something in your past or present that you might have contributed to some sort of systemic oppression, that's an important moment, because I learned that when I felt that, that's when I really was beginning to recognize something fundamentally important about how this country works. And sitting with that and using that to drive you to learn more about why you felt that way and asking why. And I think that's what we learn is important in medicine and science, but we don't apply it enough in our daily life. If you see something, ask why. Why is that person in that condition? Okay, they're homeless. Why? Really, why? Why are they homeless? And if they don't have any system set up to be able to provide them with the resources that they need to get out of the situation, why? Right? And you keep going to the point where you'll understand it's on us. If there's something in society where we see that there's someone that's not receiving the care that they need, that's because we failed them, not because they've failed. And that's why we're here, that we've always seen ourselves as individuals and not as a community. And it might be something that's very integral to American society, right? Individualism. And I think there's something for me, I went into infectious diseases because I understood at a very young age, when I lived in India growing up, I saw around me that infectious diseases are just a manifestation of inequity and systemic oppression. And sure, it looks like people getting sick, but I realized that my people get sick, but they don't. And there's a reason that that discrepancy happens, right? So even as a kid, I knew there was fundamentally something wrong about this. And pursuing that answer, like let that drive, if you're going into healthcare or anything else, really, let that be the drive, because you'll, I guess, see sooner or later that there's a reason that we're in this first place, especially when we're talking about testing. We were not unprepared because we got to this point and certain systems failed us. We were never prepared to begin with.
Yeah.
I never for a moment when COVID happened felt like we would possibly be equipped. It didn't matter if we changed all of our government leadership and we got the most competent people there when we fundamentally have a healthcare system that prioritizes profits over people. When we fundamentally have 2.5% of our budget in healthcare going to public health, right? Which is prevention, and everything else going to being reactionary. Yeah. Because that's what we do as a country. Every time there's a pandemic, Ebola, throw money at it. That's it. Zika, throw money at it. That's it. HIV, AIDS. After everyone's already been, decimated by it, throw money at it, right? That's not how it works though. We need to be prepared because we're fundamentally addressing the underlying conditions in society that cause bad health to emerge in the first place. And if we're not taking care of people and giving each other compassion and making sure we know that we are responsible for every single person that's around us, infectious diseases is like the perfect thing to remind you of that, right? It doesn't matter at what level of society you exist in. We're clearly understanding right now that if we don't all get it right, if we don't all understand the importance of wearing masks, if we don't all understand the importance of adhering to these policies, but even then, some people get to stay home because they have a home. Some people get to stay home and work because they have jobs that allow them to work remotely. So what happens when you're in a society where certain people have no option but to go because they're considered essential workers, right? But to be the backbone of society because they're working in sanitation or grocery or meat packing facilities, or they're incarcerated, where our 10 largest COVID clusters have been correctional facilities. So that's the world that we live in, right? That this is not a society that's fundamentally going to last when you have such a big disaster hit, unless we fundamentally restructure the entire way that we exist. And I think that's why what Dr. Talamantes said was so important, that we need to take down these systems and actually create something better that's fundamentally about taking care of each other, not profiting off of each other or taking advantage of each other or excluding each other. And that's really the system that we exist in. And we're trying to do our best, I think. And as you go through your career, remember that you're going to have to live within the system. You're going to have to survive within the system, and it's going to probably hurt, but you can do work outside and inside the system. You can work in your community and you can get a good education because you just have to right now. And that's okay. And I've guilted myself for a long time, even going into science and medicine, feeling bad. Don't feel bad because this is the route that you need to take right now. Equip yourself with the skills and get to a point in your life where you can actually help your community the way you need to help them. And that's okay if you're not there yet.
I mean, I think that guilt is real. And I just want to second, I think what you just said was phenomenal. And I think that guilt is okay, but we have to go beyond that. So after George Floyd, for example, I wrote a piece about turning words into action, because I felt that there were so many words, people I haven't even spoken to in forever, texting me, how are you? How are your family? How are your kids? And I love that people were coming together and recognizing, shocking to me for the first time, that this is a problem, that police and unjust treatment is a problem in police and also in other aspects of our society as well. But I think what we need to recognize now, that unless we address these root problems, the social determinants, the policies, any health crisis is going to disproportionately impact the most vulnerable populations. Okay, so anytime you hit a system or a country or a population of people with a crisis, it's the people who are the worst off at the starting point who are going to be worse off at the end of the crisis. So we have people who are hanging on by a thread, and we're throwing them into a health catastrophe. We're giving them very few resources. And as was just mentioned, we're asking them to go to work. Who is delivering your mail? Who is delivering your takeout food? Who is the person who is working in your grocery store or your Target? It's the people who are primarily ethnic and racial minorities. These are the people who are out in the community and have to work. And of course, they're going to be more susceptible to getting the virus. They also live in living conditions where they can't socially distance. They often have multiple families living close together, 6 feet away. I mean, what happened in New York City was because people in New York City love New York City, but they live on top of each other. It's very hard to control a virus when you are set up in an environment that is the opposite of virus control. So again, my caution and my concern now is I love that there's so much rich discussion about all of this, but I think we need to move towards the action items. And I hope that we can emerge from this pandemic, from George Floyd, from this year, and move towards actual policy and structural changes so that we don't have another disaster like this moving down the line.
All right, so last question of the prepared questions, and this is to all the panelists. Um, why are the minority communities experiencing more severe impacts of COVID-19?
Well, I'll share. One of the things that is important as we recognize this from the vantage point that we're in California is that minority communities are becoming the majority, and part of that is important to recognize because racism is bad for everybody. It's not just bad for minority communities; it is bad for the majority. And as we become the majority, it's important that we recognize how to really understand where we want to go. So let's talk a little bit about vision and where we want to go. Before the pandemic, California was on a trajectory to provide health coverage to all. What happens when you create a system where we can provide health coverage for all is that now you're able to really understand what is it going to take. Because if you cover everyone like the ACA has, what it did is it brought up a lot of issues. Before the pandemic, and still today, I practice in what we call physician shortage areas or healthcare shortage areas. Well, those still exist, and if anything, they've been exacerbated, and not just in the urban cities, but also in rural areas. We know that there's a limited healthcare infrastructure. The vision is really how do we create a healthcare system that is about prevention, that keeps everyone, keeps individuals from getting a cancer or any other chronic disease like diabetes, hypertension, or heart failure, or other failures of organ systems that we know are very common. And how do we use technology? I mean, I think there's a lot of ways today, and I think it's been a blessing to have COVID-19 pandemic, the COVID-19 pandemic hit, because at least for our healthcare system specifically, it forced us to challenge everything we did and how we did it. It forced us to rethink how we're going to overcome this, how to reimagine how we're going to provide services. And the reality is that there is a lot more we can do. I think we've proven to ourselves, and yes, there are some communities that we're very worried about, and we're going to have to do more. And that's okay. That's a challenge for all of us. But I do hope that moving forward in California, in the country, if we can do this for the entire country, is that we do need to move to building a more equitable healthcare system that isn't going to leave anyone specifically behind. I think that there's this belief that again fundamentally is racist, right? I heard it going to med school. Well, that person says they're poor and they're on Medicaid or Medi-Cal, but why do they have a cell phone, right? Like this belief that because someone has a cell phone, they're wealthy. And again, they're not deserving, right? It's us making a judgment call about who deserves healthcare and who doesn't. But fast forward, if we don't get ahead of this, to Dr. May's points and some of these modeling studies, is it really, does it really make sense for our country to pay millions, maybe in the billions of dollars in treating people when they get cancer in the hospital at the end of their life, right? Really expending all our money at the end of life. And then I have a young woman who's in her 20s who, for whatever reason, is losing her kidneys and she can't get a kidney transplant, right? I mean, that's the disparities that we see every day, is that if we're going to spend all our money one way, we leave a whole nother generation without. And it's not just healthcare. Every time we spend more money in healthcare specifically, we take away from education, we take away from our communities and the way they're built, parks. I mean, all the things that we want to see that we know actually lead to good health outcomes. So I do hope we get back on this track to make sure we make healthcare more equitable in California, that we're a lot more inclusive. And at the end of the day, we know the studies and they show that if we have more healthcare coverage within a community, as you look at health access as well, is that everyone does well, not just the minorities, not just the racially ethnic vulnerable, it's everyone. And I think that's part of this too, is that we're getting beat by many other countries. I mean, you got to read this article that just came out today or yesterday around how Africa has beat COVID-19. And we have this idea in our head that we're better than them, that Africa, for whatever reason, right, because it's a Black country, that they're limited. How is it that a country that we've mistakenly called, not good enough, how is it that they're doing better? Well, that's because in minority communities, there is this whole phenomena called resilience. And resilience leads to innovation. It pushes all of us to move forward. And I think that's part of it too, is don't underestimate how important we all are to solving some of these inequities. And it's just not one group or another, it's everyone really coming together. So thank you.
Well, alrighty. So this concludes our panel for today. Big thank you to Dr. May, Dr. Talamantes, and Dr. Khan for taking the time out of their day and informing us about certain health inequities that exist in the system. And a big shout out to Volunteer Center for organizing such a wonderful event.
Thank you for having us.